good morning for those of you from from my perspective at least, the extreme west of the globe, and good evening for the people in Europe and South Africa. Thank you for joining. This is the third introductory webinar for Charm. We will be recording the session because many of the partners cannot join us because of time differences. We have presentations today. We have about, let's say, 1.5 hours, so we'll try to stop around 7 our time. We have 3 presentations in the order in which they will present. First, Laura Wittman, Charm Partner from Stanford, California, and then Erwin and Yahira from La Sabana University, Colombia. Many thanks for wanting to give this presentation. We were supposed to have a presentation also by another colleague of Erwin and Yahira's, but unfortunately he had let's say, a serious medical issue, but we just heard that he's okay. So Laura, can I ask you to start? You have slides to share?
Yeah.
So what we do usually is, let's say, about 20 minutes, and then to take some time for some questions, and then we'll move on to the second. So maybe Yahira can come second, okay. And then so Erwin third.
This should work. Tell me if that is working.
I see a change, but I don't see the slides yet.
Now so I'm having trouble hearing you now that I'm sharing my slides.
Maybe you can send the presentation to us and we'll try to share.
Okay. So I stopped. Did you see my sharing?
I saw there was a change, but we didn't see the slides. We saw I saw a white screen.
Okay, so yeah, from my perspective, it started to freeze when I was sharing. Let me try it again. It's a little bit worrisome. Okay, I'll try again.
Yeah, it seems to work now.
Yeah, perfect. Now it works. Okay. Otherwise, I would have suggested to send it to me, but no problem.
Perfect.
Okay, good. I'm relieved. All right, so we can get started. Thank you. Thank you, Jürgen and Zoe, for organizing, and thank you everyone for being here. So I'm going to, let's see. Now I have to advance the slides. Okay, here we go. Okay, so I'm going to talk about my book, Faith in the Age of Irony, which is a cultural history of Lazarus stories from the last 150 years in Europe and in the United States. And I work with about 36 novels, plays, poems, and short stories. And I'm going to give just a few examples today and give you hopefully a sense of the main through line of the book. As a literary scholar, my goal is to read Lazarus stories in order to explore modern Western culture's shifting imagination of death, dying, and the afterlife. It is my conviction that how we imagine these things, how we construct them in our culture, affects the real world profoundly. It shapes what we expect and how we experience our own dying, how we accompany others, and how we create policies to care for those who are close to death. A word about my title. I will say more about faith and irony as we go, but I want to make clear that my claim is not that we need a specific faith, or in fact a religious faith, to reimagine death. Rather, I propose that we need to believe something. It might be as simple as believing that a community that will genuinely witness our dying. And I argue that this has actually been exceedingly difficult.
I'm sorry, something is going wrong.
Noise, which is
we cannot. Yeah, there is noise from I don't know where.
My guess is that it's Carla's microphone, but I'm not sure.
Okay.
Because her sign was sort of blinking on my computer.
Okay.
I just turned my Mac off.
Okay.
I put it back on. There's obviously, but I'll put it back off.
Yeah.
So
Okay. Great. All right. I'll continue. So one thing I'm working with in the book is that death has become this terrifying blank space, and I'm sort of telling the story of how we got there, but also of how we see seeds of a new imagination of death and dying, and I'll talk about that at the very end a little bit. So I start the book with an overview of what comes before the modern situation per se. So before the 19th century, there are pretty much no literary representations of Lazarus, but there is a lively tradition in painting that has some interesting things to tell us. In the Gospel of John, we read about the sisters Mary and Martha who send a message to Jesus telling him that their brother Lazarus, whom thou lovest, is dead after a sudden illness. And note this friendship and this love, which will be important to me towards the end. In one of our oldest depictions of these events, we see Jesus calling forth Lazarus from the tomb. Despite the obvious focus on Jesus and his power, this image has a mysterious quality. Faith is an inward thing. In the early Christian context, it is still poorly defined or not yet institutionalized. And there is a feeling here of something not fully understood or understandable, and there are no witnesses, and Lazarus's body is nearly invisible. More than 1,000 years later, at the height of Christian culture, Lazarus's resurrection is a major public event. Established Christian doctrine sees this story as a prefiguration of the crucifixion and resurrection of Jesus himself. In Tintoretto's painting, Jesus is the focus of everyone's gaze. The contrast between these first two slides already suggests some questions that will become important later. Is death a public or a private event, and what role do institutions play in our experience of it? And, not quite the same question, is death fundamentally solitary, or if not, what sort of relation or interpersonal aspect does it have? As we move from Renaissance into Baroque art, there is a heightened drama, a more contrasted chiaroscuro. In the body of Lazarus, the struggle between life and death is played out. Embodiment itself is becoming a protagonist. In Rembrandt's painting, it is not only the onlookers who seem in awe. Jesus channels a power that is beyond his comprehension. Moreover, is Lazarus a ghost or a living body? We could not be further from the solar, celebratory solidity of his body in Renaissance painting. Rembrandt is prescient here. A century or two later, Enlightenment debates would question the Catholic doctrine of the resurrection of the body, preferring to focus instead on the immortal soul. Even within Christianity, the fleshiness of Lazarus was starting to become uncomfortable and unscientific. In these last two paintings by Guercino and Rembrandt, a few more questions start to emerge. How central to the story is Lazarus's body rather than Jesus's power? How does culture, and especially the increasing dualism of Western culture, shape our concept of the mortal body? Can Lazarus's body reveal the spark of life that animates the material world? In Blake's image, and it is important now that Blake is also a poet, Lazarus's return causes onlookers to recoil in fear rather than to celebrate. The bodies of Lazarus and Jesus are poised between materiality and immateriality. They might be classical Greek statues becoming animated, or bloodless vampires sucking the life out of us. Their gender is uncertain. So bodily existence is saved, and we still long for something like resurrection, but not in an established religious way. Compared to earlier works, it is interesting that now uncertainty about the status of the body and its aliveness also affects Jesus himself. We don't know whether the spark of life is material or immaterial. Blake intuits that this kind of derealization of the body has something transgressive about it. It blurs boundaries, all sorts of boundaries of gender, socio-historical conditions, between mind and body, between vision and hallucination. Boundaries that the growing rationalism of the Western culture would like to maintain. We recall that between the late 18th and mid-19th century, artificial ventilation and later electrical stimulation and chest compressions developed as resuscitation techniques in Western medicine, blurring the boundaries between being dead and being alive. At this point, Lazarus' stories move decidedly into the world of fiction. Fiction has a lot of room for ambiguity, ambivalence, and uncertainty. The body can be both alive and not, or fleshy and not, at the same time. Our perception of it and belief in it can fluctuate. So the introduction of the book ends here. It has a lot more cultural context than I have time for, especially about how actual practices around death and dying changed radically between the 17th and the 19th centuries. And I also talk about how the rise of what we call the human sciences changed our understanding of death. After the introduction, the book has 3 parts and a conclusion. Each part focuses on a historical moment that has a specific cultural zeitgeist or key concept around death and dying that I explain through one key work that is a rewriting of Lazarus and 6 to 10 other related Lazarus stories and their context in medicine, psychology, religious studies, and historical events. So I'm not going to explain all of these separately today for reasons of time, but really focus on the main narrative arc that comes through, hopefully, from all of them. The main arc of my story is of how death and then dying become increasingly unnatural, opposed to life, and even traumatic. One way we see this is that in the modern Lazarus stories, and even in the now sparse visual tradition, we become obsessed with the experience of death rather than focused on the power of resurrection or the idea of the good life that Jesus traditionally represents. Modern Lazarus stories reveal a split between the individual as biological body and the individual as increasingly abstract mind. Arguably, the split happens to save the mind from extinction, but it does so only by repressing embodiment and a more holistic sense of self. Often, Lazarus longs to reclaim fully embodied life, but something holds him back. In modern works, Jesus literally disappears as we enter Lazarus's space. New questions emerge. What happened to Lazarus while his body was entombed? What does it feel like to come back? How does the one who returned relate to others? Isn't his knowledge of death too direct or too inhuman, setting him apart? Does he ever fully come out of the tomb? Note how these questions imply the increasing otherness of death. It is so far outside of the natural world that it is no longer possible to return from it fully. Or you could say dying marks a break rather than a bridge between the natural and the supernatural worlds, and it is unclear how we might traverse it. In Andreev's 1907 novella, Lazarus smells of death, and his gaze is so haunting that it throws anyone who looks into his eyes into suicidal despair. His silence is unbearable for the whole community, and he is eventually banished into the desert. His eyes are gouged out. Like death itself, he is entirely exiled from human culture and habitation. Yet, of course, like death, he remains present from afar, even if we cannot bear to look at him. At the other end of my story, in the post-war moment, Lazarus is almost always alone. In Jacob Epstein's sculpture, Lazarus's body twists against the grave cloths that bind him, bending his head backwards, exposing his throat. In those same years, the French novelist Jean Cayrol, who wrote a Lazarus trilogy, described his struggle as a word that cannot find its lips. Here, Lazarus struggles against the unspeakability of death. Cayrol was a concentration camp survivor who specifically found in Lazarus an image of those who returned from the camps and how they could never fully return to life. Given its date, Epstein's statue also refers to World War II trauma. But by its location in the New College Chapel at Oxford, the statue also suggests that we as moderns struggle to witness death, to allow it a voice that would unbind this imprisoned body. In fact, it is my contention in the book that as we have increasingly become obsessed with the unnatural or horrific quality of death, we have also increasingly adopted the model of trauma for dying. We see this in a number of ways. One is simply that Lazarus, the one we interrogate to find out what it is like to die, is increasingly associated with historical traumas. Orozco's drawing might be about a Nazi concentration camp, but it could also refer to slavery, colonization, or economic imperialism. In Borges's 1933 short story about Lazarus Morel, these parallels are made explicit. Biopolitics is expressed in a drawing where Lazarus's traumatic return seems to affect all of those around him, as they too seem to be growing more skeletal. The Jesus figure is not a body at all, but a flat white pane juxtaposed with a black one, suggesting a break or a cut. If there is another side, it is a cipher. But trauma also becomes increasingly present through Lazarus's solitude and inability to remember what happened to him. Remarkably, in not a single modern Western work does Lazarus have anything to say about the afterlife, or in fact, what happened while he was dead. In the large majority of works, he suffers from a mutism that recalls traumatized soldiers from both world wars. In Borges's 1925 play, Lazarus says that he cannot believe in his own resurrection. Redon's image is haunting. What has happened to Lazarus? His face and his hands evidence his personhood, call forth our identification with a sort of bare humanity. But there is no world here. Who is Lazarus? He cannot speak, he cannot connect. He does not look at us or expect to be seen. He despairs, one might say, even of death, and this is the destructive irony of my title. His body speaks to us, but following a specific model of trauma, which I call inexpressible trauma, he cannot tell or even fully remember his own story. As trauma has entered the popular and artistic imagination, going well beyond psychology and psychiatry, this model of trauma manifests our fears and hopes as much as it reflects clinical practice, and probably more. Just a few words on what I mean by inexpressible trauma. Jung and Leys both seeks to historicize our concept of trauma so that we can question what they see as the various interests, institutions, and moral arguments mobilized in favor of specific views of trauma for very specific reasons at specific moments in time. As Leys outlines in her book, there is a growing trend in the 20th century that imagines trauma as an event that cannot be understood, in which the victim is somehow not fully present, so that it leaves traces in their body, but cannot be fully verbalized. To simplify, this is the body keeps the score idea. But Leys argues, and I agree with her, there is a big difference between saying a victim cannot remember their trauma and this is a genuine part of the damage done, versus conceiving of trauma as essentially, fundamentally, and forever inexpressible directly by the victim. The latter deprives victims of the possibility of speaking for themselves. It means others must speak for them or even appropriate their voices, rather than speak with them or help them find their own voices. In Jung's view, while PTSD seems to accord victims more compassion than, say, shell shock in the early 20th century, it tends to push trauma into the biological, emphasizing medical causes and solutions at the expense of political or existential ones. The body as victim has no say in the causes of its suffering. In my view, it is concerning to make this sort of inexpressible and purely biological trauma the model, the blueprint for dying. It configures death as a radical break against which medicine fights to the end. This means the dying person is as voiceless as the trauma victim. What happens to them is buried in their body. A comparison and contrast can illustrate how inured we are to the idea of death as an unnatural break, and thus to dying as traumatic. San Martino's veiled Christ is dead. This is a deposition. But the veil covering the body is so lifelike that legend has it that San Martino used an actual cloth veil that he somehow petrified over his statue. This creates a profound pathos. It is as though the last breath exhaled stirred the cloth one more time as it fell into place. In this body, unlike the body of the modern Lazarus, death is neither unnatural nor traumatic. Now past the horror of the crucifixion, this body is vulnerable, a little feminized, abandoned on its bier. We contemplate it and we experience awe at our own fragility, at the mystery of the life that is gone. In our grief, we contemplate the release from suffering. In short, embodiment itself speaks here both suffering and release. Epstein's work is very much the opposite. There is no release here, no last breath, and even in its verticality, this Lazarus implies that our only attitude towards death can be one of endless struggle. There is no possibility of reconciliation with mortality. In André Malraux's 1974 Lazarus, many different instantiations of Lazarus throughout modern history are connected. Malraux suffered a series of seizures and was hospitalized in 1972, becoming himself a Lazarus figure. In the hospital, he relives other Lazarus moments that somehow compensate for his own loss of consciousness and memory. Some are moments from his own previous life. They include his capture by the Germans in 1940 and various moments when he risked his life during the resistance in 1944 and 45. But Malraux also interestingly relives in scare quotes, Lazarus moments from his own fiction, the historical fiction about World War I, about the poison gas attack at what he called Bulgaco in 1943. Well, the book's in 1943. It's set in 1916, where Lazarus is a soldier who risks his life to rescue the enemy. And Malraux's other political fictions, notably Man's Fate, where the Chinese revolutionary Kato gives his cyanide capsule to a comrade and faces death by burning without it. What connects all of these examples, Malraux claims, is what he calls fraternity in our rebellion against death. In this case, Lazarus does speak, but if I can put it this way, he protests rather too insistently that death is meaningful as long as we can rewrite all deaths as a sort of sacrifice that asserts fraternity. And all of these Lazarus stories compensate for Malraux's own loss of memory in the hospital. So if you read Malraux's memoir carefully, you start to hear how much he is haunted by the Salpêtrière hospital where he finds himself. This was famously a mental hospital in the 19th century where spectacles of hysterical women were on view. Malraux himself describes Lazarus as epileptic, revealing his own fear. Perhaps all of his heroic visions of Lazarus and fraternity are but hallucinations. He asks himself the question and immediately dispels it with yet another example of a heroic Lazarus. But beneath all of these heroic and traumatic examples, Malraux's memoir begins to suggest something else. Beneath the abstract and heroic value of a metaphysical death, or what he calls mort with a capital M, something more primitive emerges, a place where anguish and fraternity are merged. Angoisse and fraternité se rejoignent, as he says, and Malraux experiences what he calls trépas, which is another word for dying, but it is a word that really implies passing over, the process, the passage, the personal, embodied, vulnerable dying. So in the end, Malraux's text and more generally post-war Lazarus stories expose the limitations of the trauma model for death and dying. They also offer suggestions, glimmers towards new modes of witnessing that are not yet fully developed. So in the memoir, Malraux's doctor is a character, and he suggestively insists against Malraux, the patient, who is also a character in the memoir. He insists, the doctor, that death is a recent and incomplete discovery. In the years after Malraux's memoir, the trauma model remains dominant, but alternatives start to emerge more clearly. We see in Minguzzi's Vatican Doors, despite their Catholic context, that Lazarus remains bound up in death and unable to speak. 3 decades later, in Ophélie's image, what looks like rubber gloves evoke the hospital more directly, or perhaps just express our sense of disgust at death, since what we see what appears to be Lazarus's body deliquescing. Looking at Ophélie's work, it's also hard not to think of Beckett's famous phrase, "They give birth astride the grave," which is repeated in Peter Nadas's 2010 near-death memoir, Own Death. But the first two views are still traumatic, whereas Nadas's memoir connects human mortality to environmental awareness and a profound sense of care for the world. His community of witnesses for death expands beyond the human, suggesting new notions of dying. Going back again some 4 decades, we can recall that Kubler-Ross's pioneering work with the terminally ill and with near-death experiences was propelled by her own experiences with World War II refugees and her visit to a concentration camp in 1954. Both Nadas and Kubler-Ross explore a more relational understanding of dying, linked to an ethics of care in the strong sense of interpersonal commitment, rather than abstract moral ideology. In these alternatives, we see Lazarus as a character fade and in fact mostly disappear from literature again as a new tradition begins. And I see I'm running out of time, so I'm going to just summarize really quickly. In the conclusion of the book, I try to make some connections between this more relational understanding of dying that emerges from Lazarus stories and things that are happening today. So these are just a few examples. Marked by COVID is a grassroots group that wants to commemorate COVID, people who died by COVID, but is also very politicized around healthcare. This is, and the French Citizens Commission around the end of life and the right to die is also a really interesting manifestation of a more interrelational conversation around death and dying. Another set of examples that I find fascinating is that there is a huge number of television shows around death and dying and people who come back. So much so that I think I'm going to end up writing, I thought it would be the conclusion of this book, but I think it might actually be a whole other book on its own. And then I wanted to conclude a little bit just looking at various places where an ethics of care is being explored in a more theoretical fashion, both as a specifically medical and also as a feminist and activist. All of these ideas are coming into it. And I just wanted to mention the last thing that you see there, the documentary. This was a documentary about a unique nursing home for dementia patients where caregivers have extensive training and time to engage in dialogue with the patients, and it's both verbal and nonverbal dialogue. And you literally, in the documentary, you really see patients who start off kind of frozen, like Epstein's Lazarus, and they manage to communicate. When they have people with them who expect them to be communicative, who are able to listen, then they actually start to be able to communicate. And sometimes what they communicate is really sad, and they are scared and terrified, and it's hard to watch. So you understand why people often don't want to communicate. But it's a great example, I think, of this ethics of care. And then I'm going to just, I had a couple slides about what we're doing at Stanford. We have a workshop that is around, a lot of medical anthropologists come through it, but also artists, doctors, researchers. And then we have a big Medicine and the Muse program at the med school, which does mainly creative work, creative writing, music, other artistic practices for caregivers and patients. All right, thank you very much. And I'm going to figure out how to stop sharing. Here we go.
Thank you, Laura. Fascinating. I think I was going to say I look forward to reading the book, but I should use the plural. I think I'll look forward to reading both books that you're probably going to write. We have time for a question. We are not necessarily running too late, but I think we have time for a question. If somebody wants to ask a question, you can also do it. I can see, I saw a hand. I think it's Carla. Carla? I'm not sure whether that's a hand for a question or you're just clapping.
It is. No, I clapped and it's a hand for question. Oh, but now my camera has decided it will not share.
Okay.
Laura, thank you so much. That was absolutely fascinating. I have two questions that just come from the kind of discussions around trauma and managing trauma that's been going on in the health sciences faculty that I work in. And so my first question was, in your configurings or readings around trauma and death and PTSD. So the pushback at the moment here is that notions of PTSD are too event specific, and in a context where people are living in ongoing continuous trauma, the PTSD model, so it does make sense. So this has come up a lot around discussions of areas of high violence in South Africa. So if every day you're dealing with, your kids potentially being shot by a gun, by a bullet that's going because of gang warfare in an area, the notion of PTSD doesn't hold in the same way because it's more a continuous trauma. So I was just really interested if that any of that discussion came up in the readings linked to death and trauma and care in the work that you've done for the book. And then if I can sneak in a second one, but you can choose to only answer one because obviously I realize I'm stealing airtime. There's still an ongoing fuffle on our health science campus about Kubler-Ross. Okay, so I have colleagues who repeatedly teach Kubler-Ross, and then I have colleagues who've come out of, kind of social work and psychology who want to have 58 kittens every time anybody says Kubler-Ross. So I just quite intrigued about how that discussion plays out both in the work but also at Stanford in the actual health sciences campus. So thank you.
Yeah, absolutely. I mean, maybe I'll start with your second question. I think the situation at Stanford is what you describe as well. Some people are, fascinated by her and her legacy, and others are indeed sort of horrified. In terms of how I have seen, how I'm engaging with the work, the polarization that you describe happening and that I've seen here as well is a polarization that happens around near death, right? There's a whole phenomenon of literature about near death experiences that it's almost required that you see the light and you go through the tunnel and you see, and if you don't achieve that, you've failed at your near death vision, which is a big problem, right? So what I see in the literature is that in the works of fiction, there's a huge variety, and it allows people to push back against that model of, if you don't see the tunnel in the light, you've failed, right?
Yeah.
And I think in the creative work, there's a huge variety. People feel allowed to explore all kinds of other options. And now that I think there's also a growing, how can I call it? The memoirs are starting to be much more varied. So this tunnel and light memoir is no longer as dominant. So Peter Nadas's work, Own Death, is very interesting because he's a photographer and a writer, and he had a brain aneurysm and he nearly died, and then he wrote about it. But coming at it as a person with a practice of writing to begin with, he writes about it in an extremely creative way. So it's very interesting. Now, your question about trauma and PTSD, I think absolutely that we're kind of realizing, I mean, in the States, PTSD is very connected to still how the military wants to define it and what's useful. And so a big concern is that it's making it not just one event, but also depoliticizing it. So taking it away from the context of, the political and social and the context of being in a situation where you are being re-traumatized all the time, that it's important politically as well. So there's pushback against that. And the scholars that I mentioned, Ruth Lace and Alan Young, they both try to push against this kind of politicization of trauma.
Thank you.
Yeah.
Okay, thanks, Laura, for the answer. Thanks, Carla, for the question. I think we'll have to move on now to our second and third speakers, both from University of La Sabana in Colombia. I think Yahira was going to go first, and you will talk to us about, if I'm not mistaken, mental health and medical humanities as a topic.
Yeah, thank you.
The electronic floor is yours.
Yeah, I am trying to share my presentation.
We can see it. It works.
Yeah.
Okay.
So yeah, first of all, I would like to grateful to the Consortium for Mental Health for Health Humanities, Art, Reading, and Medicine for the invitation to participate in this third term webinar. So I enjoyed a lot the first presentation, Laura. Thank you very much, because I enjoyed a lot that. I am a psychiatrist, so I had been working at La Sabana University more than 20 years. And at the beginning in my professional career, my first approach was with our university hospital as a psychiatrist, and my job was so consistent in treat patients of rehabilitation for neurological conditions. For me, it was a different experience because I finished my psychiatry in a public university, and I had been in public hospitals where most of the people thought that the patients with mental health disorders were different to the other patients. And it makes sense when you talk about the historical issues about literature or mental health or units for mental health in the past. And now, with the time, I learned that many people think that the patient with mental health had a big illness that avoid that they have they are freedom to do some decisions in their lives. So as a psychiatry, now I will share with you my experience in how we can improve the humanism when we focus our effort in mental health of the people, and at the end of the day, we can change the world. Maybe it could be a little ambitious, but I really believe we can do it. And I'm going to talk about mental health and psychiatry and our classes in our medicine school. And after that, I'm going to talk about our experience with the Carter Center in Colombia and in Latin America countries. And finally, I would like to share with you how we are working in a program or guide to help our students and all university population to promote, prevent, and give first aids in mental health, because we know that as in other places in the world have been increasing risk factors for mental disorders as anxiety, depression, and suicide. So we have the responsibility to do something about that. So in medicine school, we have some classes in psychiatry, obviously. We practice with the students in simulated hospital training and standardized assessment to teach them how they can communicate with the patients and with the colleagues about mental health in general. But also we have some classes in surgeries, gynecology, and internal medicine, because we have to work together to give our students the general perception about our patients. We think that if you don't see the patient in integral, you part of the patient. Mental health is the same of the physical health. So we have to work with the patient integrally. And the second is this is a medical school, but we have also an experience in education for journalists in mental health. We start this program in 2012 with the Carter Center. Mrs. Rosalind Carter had a program for fellowship and the topics and mental health, and to try to avoid a stigma in patients and in population with mental health disorders. So we had this project between 2012 and 2021. What was our object in our work with them? To work about avoid a stigma, the mark thing that it is the sin of slavery. If you remember the presentation of Laura, we remain how the people think that the people with mental disorders have a big problem, and they have the condition invades and nullifies the rest of the elements of their identity. So as a physical, as medical doctors, we have problems to explain to the other specialties that when we have patients of psychiatry, it's the same like a patient with cardiologist illness or other illness. The stigma in mental health gives the perception of irresponsibility, inability, and dangerousness. That is totally false, because many of our patients are in this capacity to defend this his thoughts and behavior. So what is the stigma implication? Brand that links to undesirable characteristics. We don't know how is the position with the people that thinks that mental health supreme the other condition of the people. They have difficulties to difficulties in accessing and maintaining employing, access to the mental health services, and the patient affects in contacts, family and mental health professionals. As me, as a psychiatrist, I feel so stigma about a psychiatrist, as me as a psychiatrist. What other implications have the stigma in our patients? Maybe, like Laura said, culturally in Western societies, morality and virtue, health and reason mark the definition of the mental health in the people. So many people link demoniac, perverse, promiscuous, and sinful image places with horror, and the people don't understand how suffer patients with mental health disorders. Currently, a marginal and inferior group is obviously we have to do. The basis of stigma is negative stereotype, and it influences the lack of help or treatment. As a psychiatrist, I have been patients that have jobs, high jobs, and they don't or they avoid that other people know that they are in psychiatric consult. How we work with the patients to avoid this stigma between La Sabana University, the Carter Center, our patients, our university hospital. We have to do psychological interventions, maybe cognitive and behavioral, and modify stigmatizing beliefs and schemes. We have to do that. The people have to know that the stigma exists, and they have to accept the existence of stigmatizing stereotypes and do not challenge them. So we have to work with them in skills to defend themselves. And in addition, we have to remove labels, defend and support groups for people with mental illness, and to have leadership by famous and representative people with mental illness or family members with mental illness to talk in many ways, for example, in media, talking about his disorder or something like that. Also, we have to work in myths. In education, we have to educate our students, our colleagues, and population in general, and mental disorders, and how we treat these patients. But other myths would be mental disorders are due to trauma, mental, weak character, or something like that. Lack of will, for example. Patients with mental disorder are violent or dangerous is a myth, or mental disorders are incurable, because we know that, for example, anxiety, depression, or prevention in suicide, we have to do, and we can do something to improve the mental health. In our program, we have been working with a lot of media, as Caracol, Revista Semana, El Tiempo, El Espectador, Radio Macondo, RCN, La Silla Vacía, La FM. Now we are working with Latin American countries, so we have some fellows from Mexico, Brazil, Costa Rica, Argentina. Now we have 2 fellows from Ecuador. So in the program, we have an annual training at the Carter Center in Atlanta. We as a medicine faculty and communication faculty, go to the Carter Center, and we have to go with our fellowship that we select in Colombia, and they have 3 days to training about mental health and stigma, and they are receiving support by experts in psychology and psychiatry and communication too. So every year we have these kind of meetings, and since we started the program in 2013, we had to go to the media because it's difficult for journalists displaced to the other places that they work. So we had to go to Cali, Medellin, Barranquilla, Armenia, to talk about our program and to select the journalists to apply to the program of fellowship. So we talk with them about suicide, about myths, and about mental health in general. And in addition, we start education about how to protect himself in mental health as a journalist. So this is some meetings in La Sabana University, Barranquilla, El Tiempo, and we did some kind of events with some psychiatrists from other countries and psychologists from the Carter Center, and we work with other specialties in relation with mental health and our students. So in this case, in Cartagena, we work with the Carter Center. Rebecca Palpan was the director of the program, and we talk about stigma, media, and how to protect the mental health. In addition, we participate in some activities to media. For example, in this case was about suicide in young people, because in that time, 2017, increased our rate of suicide. So we talk about that in media. And in that time, we talk about depression, anxiety as a cause for the suicide behavior. We start with social media, and Fernanda, she was our first fellow in the program, and she is helping us all the time trying to educate the population in general about different topics in mental health. Every year, in addition, in Colombia, we have a meeting with the directors. In 2018, they changed Rebecca Palpan for EPR. She is now the director of the mental health. Victor Garcia is the dean of the communication, or the principal representative professor of communication and mental health. He is almost psychiatrist, and they are our fellows in that time. In 2019, we talk about one topic. It's controversial: ECT, electroconvulsive therapy, because not all the people knows about this treatment, and this treatment is stigmatized because in the movies and the historical research, the reports about electroconvulsive therapy, electrochoques in the past, the people think that is a past treatment, is a terrible treatment, and now we know, as a physician, as a neurologist and psychiatrist, that ECT is very useful for people that really need this kind of treatment. So we are working about that, working in that. In 2020, we worked together with the Gabo Foundation because at the end of the program with the Carter Center, now we need to share our experience with other countries in Latin America, and the Gabo Foundation have a lot of networking, and we are working with them to select our fellows now. This is the program with the Carter Center. Now we have our own budget, and now we are educate physicians, students, and journalists with our experience. And now I am going to talk a little bit about our promotion in mental health and with our university community. So the goal is all of people in the university, students, professors, and administrators, because all of us could have a mental illness, principally anxiety or depression. So we have to do something for that. We have to improve or strengthen Línea Amiga. It's called our contact line to help students and the university population in aspect of mental health. Training for teachers in aspects of mental health, because it's the first contact with the students. And joint work, university welfare, employee welfare, human development, psychiatry, psychology, university medical center, and other central government departments of the university. This is our, in the present, is our project, principal project. But in our future, we are planning our psychiatry postgraduate, because we don't have in this moment. We have a mental health unit, 15 beds in this moment, and these beds are designed to develop our psychiatry postgraduate. We are developing an application to the orientation of patients and education in mental health for our patients. And we are working in research about national management guidelines for ECT, electroconvulsive therapy, because we start with that treatment in 2016, maybe. So this is our experience, and thank you so much. And I enjoy to be with you in this meeting. Thank you.
Thank you. Thank you very much. It sounds very fascinating. I was wondering, let's say the media that you approach, are they very open to let's say what your suggestions are? Are they eager to take these stories? Is it easy to reach them?
No, it's not easy, because they have no time, and maybe their education is to have quickly news, so they don't use a lot of experts to do the news. But with the Carter Center, it's a fellowship, so we have a budget to help them to develop a project for a year. So it is the pillar of our work with them. And at the same time, we talk about mental health in their own media institution, because it's difficult to the place to other places.
Mm.
But it's wonderful work with them.
Yeah, it's great work. Sounds fascinating. Any other questions or remarks or suggestions? I think we have some time. Laura? I saw your hand and I also saw Claire giving a sign, but you're muted both still.
So just quick question, really. I was curious about when you're working to sort of modify the stereotypes, the stigmatization. Do you do creative work with the patients too?
We have networking with the patients with, for example, bipolar disorder. We have a group of bipolar disorder with patients, and some of our events include patients in our meetings, in our lectures. So it's very useful to sensibilize the journalist.
Thank you.
Claire, you also wanted to ask something?
Yes, thank you very much, both of you. I was wondering, because Laura and you, Yahira, you presented very different kind of research and projects. And as we are speaking about medical humanities, I was wondering, how do you cope with interdisciplinarity, for instance, each of you? Laura, you are working with literature and with arts, and Yahira, you are working inside the medical faculty with patients and with media. So it's a very different, a kind of different approach. And so could you just tell us what is your approach, and how do you cope with interdisciplinarity in your respective medical humanities centers? It's a wide question, but just to start discussion.
Okay, for example, in La Sabana University, we used to work together between faculties. Medicine, psychology, la escuela, economics. So we used to work together. So actually it was easy to work with the communication and medicine faculty and to psychology. We don't have a literature or arts faculty, so it could be interesting, but we have a humanism faculty, and with them we work a little bit, but in other ways. For example, in bioethics and in humanism.
Yeah, just to comment, because the topic you have treated, perception of mental disorder, is it's also very interesting to study it from a historical perspective, because there are a lot of discussions about, for instance, demoniac explanation about mental disorder during the 17th century, for instance. So that's why I asked this question, because it could be very interesting to have this kind of crossed approach. Yeah.
But if I understand correctly, Yahira, the university itself is a fairly recent institution that is organized as an interdisciplinary organization, which I think makes a lot of difference compared to some other universities who have a longer disciplinary tradition. So that's interesting.
Yeah, I mean, just quickly, it's a really big question for us, how to ensure more conversation between the medical school and the humanities departments. And right now, we have done it through common events. And people speak from different, like today, really, from very different fields come together. And we try to build, we're starting to talk about what that would look like as a curriculum. In other words, would medical students, could they do humanities courses in our departments? Because right now they have a medical humanities course at the medical school, but it's all over there, as it were. And how could they come to us? And similarly, some of our students in the humanities are asking, instead of reading about, psychiatry or what it's like to be a medical student or to go on grand rounds, why can't I go? I want to experience it. So we're hoping to make that happen so that there's more connection, you know. And in my work, I mean, I try to, you know, as you saw at the end, right, make these connections between what is very sort of historical to some present events, you know. So I'm really interested in how in some places people are working with psychiatric patients and they're trying to create myths or mythical stories that will present these conditions in a less negative and stereotyped and stigmatized manner. So they're actually trying to make cultural transformation, and that's really fascinating.
Thank you.
Great. Thank you.
Yeah, I think it's a good question, Claire. It's also one we could take as a central focus of our kickoff event also, because it would be fascinating to hear how each of us from different traditions, from different countries, from different continents deal with that difficult issue. So great suggestion.
Yeah, thank you very much, both of you.
Thank you very much.
I was also thinking, just very shortly, Yahira, here in Ghent, there is a larger consortium dedicated to also improving mental health of all citizens, and it's also a group which works together with different stakeholders, and they really want to generate real world impact. So I will send you the link to the consortium too. Maybe it can work, or it can make you inspired by it too. So now we have to move on to the last speaker. I'm pleased. Now I see you. I'm very pleased to introduce to you Erwin Hernando, also of the University La Sabana in Colombia. Yeah, again, the floor is yours, or as Jürgen says, the electronic floor.
Very much.
Can you see the presentation?
Yes.
Yes, thank you.
Yeah.
Okay. Okay. Sorry for my English, but I try to explain this presentation. Okay. Hi everyone. My name is Erwin Hernández, and I am an associate professor at the Faculty of School of Medicine of the Universidad de La Sabana. Today, I am eager to discuss the profound importance to engage directly with communities to understand and address their true health needs. This approach is fundamental in our university and shapes much our work. In today's presentation, we will begin by exploring the rich and complex context of Colombia, followed by insights from our experience at Universidad de La Sabana. We will into how we integrate with community, health leaders, and rather with reflections or impactful journey. Colombia in the first place is one of the most ethnically and culturally diverse countries in the world. This diversity includes indigenous and indigenous Amerindian populations, Afro-descendants communities, and a history of European colonial influence. Understand this diversity is crucial and it directly impacts our approach to community health. The culture and natural richness of Colombia, from the vibrant Guatapé in Antioquia and the San Andres Islands, presents unique challenges in healthcare delivery. For me, Colombia is the most beautiful country in the world. Additionally, these regions not only offer stunning views, but also illustrative the complexities of providing health service across diversity infrastructure. Colombia, additionally, Colombia's beauty is innegable, but it contrasts with challenge. Regions like the River of Seven Colors in Meta and Leticia in Amazonas showcase significant social inequalities and varied health profiles, challenge of tailor of health strategies effectively. But Colombia is one of the most inequality country in the world. Because Colombia has different problems. For example, in the center of the country, we have an incidence of chronic illness, but in the peripheral areas, we have illness derived of poverty. For example, desnutrition. For example, maternal mortality, among others. Colombia has a health system that it was conceived of as a model with healthcare and equity in the population. It is a model comprehensive, supportive, and universal. But Colombia, this health system has different problems. For example, it's focused in of curative care and illness. It's centered in the hospital. It's super specialized. It's fragmented, and has a implementation according to the interest of some actors. Disparity in the additionally in the radius of medical and nursing staff compared with other countries highlights a significant challenge in our health system. For example, Colombia have a lack of personnel of health compared with other countries, and addressing storage of healthcare professions is a critical for improving health service and delivery across of diverse population. On the other hand, this topic is important because in order to resolving health needs, 5 actors are necessary to stabilize a link. In the first place, decision makers, the academy, the human resource of health institutions, and community have integrate in order to resolve health needs. And this is the focus of the Universidad de la Sabana, the importance to integrate with different actors. Additionally, Universidad de la Sabana have a focus in which teaching and investigation has to and community engagement integrates the institutional approach of Universidad de la Sabana, that it means a social projections, and this focus is oriented to solve real problems, providing practical relevance to our educational content, and it's important that the methodological approach of service learning of our students. Our School of Medicine is dedicated to shaping future medical professionals who are not only skilled but deeply commit to community health and primary health. We strive to prepare our students to meet both the immediate and future health needs on the community they serve. At Universidad de la Sabana, or School of Medicine, has a long-standing commitment to integrating community health into our medical school. This integration has been pivotal since 1999, where we emphasize family medicine and community health across the various semesters. Our approach is designed to not only educate but actively engage with community, addressing their health needs through immersive learning experience. Our curriculum extends over 12 semesters with key integration of community health principles starting early in education process. For example, from the 6th semester to in 1999 to 2026, in the middle on the career, but we know we learned that was important. Change the focus in the about our students. Actually, in the new plan, new student plan, we understand the importance to teach this community health approach, the transversally in the medical curriculum. And in 2016, we made a research in order to understand the inclusion of equity focus and social determinants of health in healthcare education program in Colombia. This research was very important because they teach about the link between local necessities and the training necessities of the health personnel. In the first place, we understand the importance for universities. This topic is important, or this initiative is important in which the universities incorporate this focus in their institutional educational projects. But and it is an opportunity to ground out and research, because this generate change through critical and sensitivity. For example, one person mentions leaders of their environment, respective of the cultural, regional, and ethnic diversity of the country. And it's a good scenario or good environment to implement the primary care model. On the other hand, this focus can be understood in the study plans between the approach from the public health and primary health care. For example, it promotes a dialogue between various disciplines: anthropology, sociology, public health, and communication. But it's important that this focus will be transversal from the first semesters. And these findings from our research have profoundly changed our curriculum, stressing the importance of community-oriented health projects within educational settings. For example, this inclusion requires a process of persuasion and advocacy among the teachers, because we found a resistance in order to implement this focus. On the other hand, in the student appropriation, the student appropriation is variable because we have students who are refractory to the topic, but there are students who respond and who conceptually to the topic, to those who develop capacities to be engines to change in the community. This appropriation is acquired gradually, and it is suggested to increase appropriation from practice. What factors favoring this focus? Investigation in social problems, teachers that are convinced to this focus, the social orientation of the university, a community practice, pedagogical models, innovative, and documentation and socialization of this experience. What factors limiting this focus? Biomedical model or effective biomedical model of training, clinical practice sites, limitation of community practice sites, lack of intersectoral focus, the same health system, and professor with a clinical predominance. In conclusion, it's pertinent that academic health science programs intentionally introduce equity focus and social determinants health and the beginning of the career and transversally as the part of the professional competence. The approach of the community sensitive students to the real problems of the population, and we can exchange knowledge and know-how competence in our students. In the recommendations, it's important design improving strategies with various health and related programs in intersectorial and other programs, and it's important the resignification of social projection. It explains the global consensus for social accountability of medical schools. In other research between 2012 and 2024, we found the importance to work in community health, because this permits the integration of public health and family medicine and a curricular adjustment and integration, the integration with formative research process, the training of community leaders, and the social projection component of the university. Healthy schools we start between 1999 to 26 in the approach of healthy schools. We can cover the 30 schools, and we made the integration of health education and the environment. Actually, currently, since 2029, the focus is about healthy environments, and we change schools for vulnerable communities, and our focus is in primary healthcare that combines family medicine and community health initiative. This have evolution and interest in important evolution in which in 1999 we initiate in a plural mirror. We don't know which to be the focus. We do it. We did it as the application of national guides in health promotion reference, but with the time in the new millennium, we understand the importance to healthy schools and the integration of health education and environment. in 1 year later, we understand the importance to community priorities and the primary and secondary source of the territory. But in the 24 to 27, we changed to a community-based research that combines elements of evidence-based in public health and participatory action research in order to focus the community project with our students. In 25 to 28, we create a community health cycle that this community health cycle was applied in 2029 to 2017, and we changed the capacities in community leaders. Actually, or now, we integrate the community health leaders and students in the same place, and we can generate the adaptation to real problems. This is our community health cycle based on participatory action research and a community-oriented primary care, and we base of the Stanford University of Theory of Change. This has increased the participatory diagnosis, and the methodological elements is based to service learning and project-based learning that can construct the community health cycle. Important to the community health cycle is the two first stage. The first stage is in order to know the community. Our students visit different communities of different cultural and vulnerable situation, and in 1 and 2, 3 weeks, we generate a link between community and our students. In the second stage, we strengthen the credibility and the truth. It's the most important stage in the community health cycle, because sometimes community don't have the possibility or have some vulnerable situation that they don't like to work with medicine students. The other facts are related to the community diagnosis and plan implementation, sharing results, and continued quality, and important to improving and sustain the sustainable change. 28 types of community with different degrees of vulnerability we can include in this experience. Principally in Bogotá and Sabana Centro, this is the area of influence. Examples: community, population, elderly, childhood, education institutions, population with disabilities, street person with homeless, indigenous community, maternal health, orphan disease, an example of principal problems that our students must do an intervention. Chronic disease, respiratory disease, addictions, inclusion of of knowledge of caregivers, social inclusion and rights, intercultural health, risk factors, understanding of education of orphan disease. Finally, the integration with community health leaders has the possibility to strengthen our link with the community between our students. Since 2021, we enhanced our educational model by integrating training for community health leaders. This initiative not only empowers local leaders, but also enrich the educational experience of our students who participate in both in-person and virtual formats. This training process was recognized by Pan American Health Organization and World Health Organization in Colombia, and in the principal results, some leaders have become co-tutors of our students directly in the communities. This develop primary health projects, mostly articulate with public policy, 16 local health plans, and this contributes to the solution of real problems. Over the past 12 years, we trained approximately 420 leaders across 8 different territories, including challenging regions like La Guajira and areas bordering Venezuela. These leaders are instrumental in identifying local health problems, thereby enhancing the effectiveness of our health intervention. This is we talk three examples. In 2021, in the pandemic, in the pandemics, 11 municipalities of Sabana Centro, near of area of influence of the university, we found, or we can design different public health projects. For example, 3 municipalities define mental health disorders resulting from the COVID-19 pandemic. 3 municipalities, 2 neglect of the chronic disease during the pandemic, low vaccination coverage for the other disease, abandoning of older adults due to the pandemic, or finally increase the unemployment in mothers who have households. In the other example, in the border area with Venezuela in 2022, we found 5 problems. For example, migration crisis, dengue, armed conflict, guerrilla by the guerrilla groups, and forced displacement, violence, and low she-hold vaccination rates. Finally, in the last year, we visit Wayuu indigenous population in La Guajira, in the corner or on the country, and we found this image with the Wayuu indigenous people. In the picture, the absence of drinking or absence of water, child malnutrition, mental health in the post-pandemic, few employment options, and corruption. We have a final reflection, the possibility of addressing of diversity of problem of needs, the ethical imperative to solve problems, not only the diagnosis of the problem. It's important to solve problems. Each experience is different, different actors and context, type of community, organization, area, territory. Also, the importance of alliance between academic, decision makers, different disciplines and sectors. And finally, the importance of generating a clear critical mass of human talent in health professionals and leaders who are sensitive and competent to respond to the needs of their population. The development of community initiatives, small or large, will allow us to contribute later by later to having a great landscape. Excuse me by my English, but to conclude, engage with communities and understand the real needs is pivotal to our work at Universidad de la Sabana. Thank you for your attention.
Thank you very much, Erwin. This is it's great what you it's even impressive what you have already done and the challenges you face. If there are any questions, maybe we are a little bit running out of time, but maybe one question or a remark or a suggestion is still welcome. I was just wondering how you face, maybe I've skipped it because it was a lot of information, but given the diversity of the population in Colombia, how you face the maybe language differences. There are people who are, I think, are talking not only Spanish, but also native or indigenous languages. Is there already some problem solving going on?
Yes. We have two methodologies. The first one is now to dialogue of knowledge, or in Spanish, diálogo de saberes, dialogue of knowledge, in which methodology the student of include the medical doctor has a close dialogue with the community.
Yeah.
The medical doctor and our students can learn about the community. It's a horizontal relationship between the two communities. And the second is important, the confiance, the truth, the link between the communities. These two methodological approach are important in order to make the health projects. Sometimes we have a community traductors, but it's only a tool in order to make these public health projects.
Yeah, I can imagine it's a problem or a challenge for everyone in healthcare to face diversity. Are there other questions? No? Then I think we are done by now. I also had to excuse, I think he's still here, Jurgen, but Jurgen had to excuse or had to go. So I'm excusing him for for his early leave. And I want to thank you all for joining us this evening in my case, or this morning at the other end of the world. Thank you very much. And we'll see each other. I think Jurgen and I will mail you to meet again for an informal discussion in the running up to the kickoff event. So somewhere in June, we think. So okay,
thank you so
that's
much.
fine.
Thank you very
Thank
much.
you. Thank you very much.
Bye.
Bye, Erwin, Yahira,
Oh my God,
Carla.
thank you. Thank you very much for your
Bye-bye.
presentation.
Bye.
Bye.
Bye, everyone.